Gentlemen, if I can have your attention, those of you who are live with me in New York, I want to hear your energy. Give yourselves a round of applause. Now you see I have a live studio audience, and today, listen, we could look at the glass half empty. We could look at the pandemic shocks. We could look at climate change, food insecurity, and all of these elements are valid. But over the next 1.5 hours, we want to look at the glass half full. There are individuals, governments, CSOs that are taking their commitments to action. With that said, you are ready to how countries are reimagining and renewing global commitments to primary health care. The individuals who are going to be speaking today, I like to call them trailblazers because they are drawing the blueprint on how to prioritize primary health care in their countries. And I dare say some of their examples are easily adaptable and can be adopted anywhere you are. If you're joining us live on LinkedIn or Zoom, we're having a great time here in New York. It is morning for us. It could be afternoon or evening for you. My name is Anita Erskine. Now, just for the sake of those of us who are live with me in New York, I would kindly ask that you put your phones on silent so we avoid any disruptions. And also, if you are online and you'd like to move from English to French at any time, you can tap on the button underneath your window. Let's start the show. My first conversation will be with Bupe Sinkala, mentor mother, mothers to mothers from Zambia, and Dr. Atul Gawande, Assistant Administrator for Global Health USAID. And essentially, they'll set the spirit, the energy, and the tone for the rest of our conversations here this morning. Atul? Bupe? Well. Bupe? You're very welcome to New York, Zambia, Ghana. Dr. Atul, you're the only one left out, but it's okay.
Ohio.
That's okay, we'll take it. Bupe, I would like to start off with you. You have the first word here, and I'd like you to tell us how community-centered care impacts a woman's life.
Thank you so much. Good morning, everyone. I'm so happy to be here in New York. I could say I'm getting the hang of this. Yes, thank you for that question. So for me, coming from the ground, the one who is doing the work, it's very easy for me to share with you from a real life perspective. So I'll tell you about one of my clients. Her name is Imelda. And so she's a woman that is living with HIV and has 3 children. And just recently, she lost her husband as a result of cholera. And so me coming from the same community and found at the health facility, I saw that she was not coping emotionally. And for me, I took it upon myself and other community health workers to ensure that she got, firstly, the emotional support that she needed. And also, she also continued to take her ARV treatment, because for me that is a lived experience. I know what it can do when you're not on your treatment. I know what it can do when you're not getting that emotional support. And also I feel the trust is built in that we are coming from the very same community as our clients. I know to say we have a cholera outbreak. I am also going through the same. So it's very easy for that client to trust and also not only have them access the services, but also retain them in care, just like what we do at Mothers to Mothers. We are an African organization that trains and employs women that are living with HIV, like myself, to offer support to women, and also not just have them access the services, but retain them in care. Yes.
And that's why essentially I said commitment to action, so you are living the real life commitment to action, and we celebrate you for that. Atul, you have been a long standing advocate for PHC. What is the best case of investment?
So at USAID, we have set our job is to reduce inequities in survival between the richest and the poorest in the world and across the span in between. our measure we've made is to reduce the percentage of deaths in a country that occur before the age of 50. We know we can get that below 10% of the population, but in many of the countries we work, in Africa, for example, it's over 50% will die before the age of 50. In Asia, in many of the countries where we work, it is a similar picture. So how do we go about doing that? Well, we have our programs in maternal health. We have our programs in family planning. We have programs in child health and immunization. We have global health security to deal with emerging threats. And we partner with many countries. I see many of our friends here where we're doing this work. Every single part of it relies on strong primary health care. They are the same people. It is Bupe who is looking to see if a mother, a pregnant woman has had her prenatal visits. But then it's also Bupe that is making sure that the child is getting immunizations. And then later in life, you told me before, you have 300 client households, and you are addressing everything, including the fact that in the same household, the father died, and what the health issues were there, and so on. So the case for investing in primary health care is we can't address the health threats emerging around the world that can threaten the entire world. We cannot address the inequities in survival unless it's through primary health care.
So primary health care essentially builds resilient communities, resilient nations, etc. Bupe, imagine I gave you an opportunity to tell us what 3 things would make your work better. Not easier, because it'll never be easier, but better.
So for me to be here is a big thing. I will not make today about me. I am speaking on behalf of my fellow community health workers. Because for me, I would say I am lucky. I am employed by Mothers to Mothers, and they pay me, they train me, they support me with equipment for me to be able to do my job. But this is not the case for my fellow community health workers. And I would say it's the exception, but it's not a norm. And for me, it's really sad. And I would like that to change, because I believe community-centered care is the key to primary health care. So I am speaking on behalf of my fellow community health workers to be trained, to be supported, to be recognized, and just to have more of us on the table.
So you don't want to be the exception, you want to be the norm.
Yes.
Atul, if PHC is properly invested in and strengthened, what would look different in 10 years' time?
Well, we've already had a chance to see it. When programs like PEPFAR for HIV, the President's Malaria Initiative, and our global health investments were increased 20 years ago in the early 2000s, we saw countries like Thailand, which were lower income, had 35% of their deaths occurred before the age of 50. They had all of the range of problems that you can imagine, and a massive HIV outbreak happening there, needing to be addressed. Over time, as they rose in their economic capacity, they made a universal health coverage commitment to investing in primary care as their first priority, enabling enough nurses and community health workers and even doctors to get out to communities. And the result of that is that step by step, they have outpaced their neighbors because they made primary care their priority, and they have been able to achieve now the same life expectancy as the United States on $300 per person per year for healthcare, compared to our $12,000 per year for healthcare. That is what is possible. And we have multiple examples of countries that are now meeting high income results with middle income capacity. And I'll say one more thing about where Africa is in that journey. In the year 2000, less than a third of African states were rising to the middle income status. Today, it is 60%. And it's projected by 2035, it would be in the range of 3/4. So we are needing to build this foundation for the middle income, middle class Africa that all of us know and see is coming. And together with their countries, the U.S. is partnering, I see, with all of the ministers here and the GFF to be able to enable strong country-led systems and not just our disease and condition-based investments. We need a better primary healthcare system coming out of all of it.
Well, thank you so much, Dr. Atul Gawande, Assistant Administrator for Global Health USAID, and thank you to you, Bupe Sinkala, mentor, Mothers to Mothers. We'll be keeping an eye on you. And like we promise you will be the norm and not the exception. Thank you so much.
And now, ladies and gentlemen, we move the conversation to the concept of why primary health care delivers much more than just better health. My contributors in this panel are Honorable Dr. Louise K. Gupoto, who is the Minister of Health, Liberia. We also have Natalia Cannon, Executive Director, UNFPA. And lastly, Margaret Lubali, Executive Director of HENET, CSO Kenya. Please join me, ladies.
Honorable Minister, you can come right to my left, Margaret. Thank you very much. So, of course, I know it's a busy time for you, Honorable Minister, and I'm going to put you on the spot to start. Ladies, with all due respect, we have just about 2.5 minutes per question. As the 4 ladies, I know what we can do if we don't have a time limit. So it comes to you with respect, Honorable Minister and my dear big sisters. But Honorable Minister, I want to start off with you. Primary health care is the front line of any health emergency. Now, how did Liberia's approach to PHC change and also strengthen resilience, of course, in the aftermath of the Ebola crisis, Honorable Minister?
So I want to say thanks for having me, and thanks to GFF for organizing this section. Liberia is a country that stands at the crossroad of many crises, ranging from epidemics, pandemics, to climate change. In Liberia, the Ebola crisis started from 2014 to 2016, and that was a turning point in our health sector. The outbreak exposed how fragile the health system was, and there was immense strain that we had. At the heart of the crisis, there was about 360 health facilities at that time, reaching about 41% of the population. So in the aftermath of the Ebola crisis, we took on a journey of transformation. There was a renewed focus on primary health care, specifically at the community level. In 2015, there was an investment plan aimed at building a resilient health system. Now we can probably say that we have from 300, and that was the help of GFF, from 360 health facilities, we have approximately 750, of which initially we had like 15 hospitals, but the primary health facilities are now 760, out of which we have about 40 to 60 hospitals in the country. And as the previous speaker said, what we focused specifically on was emerging obstetric and neonatal care, emergency response, civil registration, and vital statistics, as well as adolescents' health.
Yeah.
So Liberia stands amongst the giants when it comes to community health workers. I could say we are the pace setter. So as the previous speaker spoke about the community health workers, they are on the field doing excellently well. Now the health facilities, we have community health workers going out into the health facilities and bringing in patients almost like companions for patients that are not doing very well in the community. So a case as almost, there was this lady who, the social support in where we come from is very important.
Yeah.
So she did not have that. Her husband fell from a tree in one of the remotest villages. He died. After that, she was all by herself, and she was pregnant at that time. So the community health worker ensured that she was going to her ANC care. So because of GFF, there increased vaccination, there's increased ANC care. And so we're doing a lot there now. So she went and then she had her safe delivery, and now she's doing completely well. So,
Honorable Minister, these are the kinds of stories that give us hope. You know, it's to say it's exciting is almost to downplay, you know, the light at the end of the tunnel. And I'm going to come back to you for more of these stories. But Natalia, I mean, we are talking about crises and how access to sexual and reproductive health and rights and family planning services are often disrupted. And it's happening right now in our world. How can stronger PHC mitigate these disruptions, Natalia?
Well, Anita, primary health care is the backbone. This is the way of connecting the dots. And we have pioneers in this field with us right here today who have understood that we really haven't prioritized a woman's time, a woman's ability to get transport, and her requirements. The issue for primary health care is that it's a great coordinating mechanism, and it's also a way of tracking how effective are we being. So I believe that at this point, if we are serious about taking women seriously, we also quickly come to the realization that she's the one that's going to make the decision about health for the family. Hello. And it's noble, it's so kind, it's wonderful that a mother, that the grandmother, the auntie, the neighbor will prioritize everyone else on the list except herself. So how reasonable, as we heard from Dr. Atul, to make sure that one-stop shopping is what we're doing. For example, for sexual and reproductive health, why hand out contraception alone when we can coordinate to make sure that HIV prevention is part of that package? I heard just a few moments ago, Mentor Bupe talk about the mental health strains that people are undergoing. If that person is female, should she suffer in silence? For me, I'm in flaming orange today because we orange the world against gender-based violence. We have to be sure that we ask the woman when she arrives, is anything troubling you? Can we help to prevent a disaster before it occurs? And my last point about primary health care, it's really cheap for what you get. We have studied the 3 zeros, ending maternal mortality, so important, Asia, Africa, around the world. Minister Mohammed Pate, I'm sure, will speak to this. We also have to zero the unmet need for contraception. This is empowerment, when you can decide how many children and how to space them and when and with whom. And of course, the third 0 to 0, harmful practices and gender-based violence. For $22 billion a year for the entire world, right? For 10 years, we would have huge impact. And these are types of figures that are attainable. So we want to emphasize that in an era where we have drought, we have flood, we have conflict, sadly, and I know Liberia has also pioneered the peace where women played such a big role. That $22 billion is going to be so cost effective for us to make sure that women's needs are prioritized, and that's going to be to the benefit of the entire family, community, and world.
Absolutely. I tried to find something orange. I just read
No, well done, well done, well done.
You know, in support of UNFPA, and that's not a joke. So I bring it to you, Margaret. What role is civil society playing in ensuring that better access to quality PHC services are prioritized?
Thank you very much. I think one of the things that we have to recognize is that the environment in which CSOs are working is not getting any easy. We have tight fiscal space. We have the pandemic shocks, as you talked about, as you began. And so the tendency is to imagine that CSOs should slow down. But I say when the going gets tough, the tough have to get going. And so you look at 2030, SDGs are coming to an end, and UHC 2030 is also coming to an end, and 50% of the world still doesn't get essential services. We have 2 billion people that are teetering on the brink of poverty because of out-of-pocket expenditure. And so that's the background within which we work. And so the question is not really what role do we play, but how can we strengthen and coalesce better to be able to run against the race, the time, the clock is ticking. And so globally, CSOs are coalescing, the CSEM, UHC 2030, the Pandemic Action Network. There are many networks that have come together because there is strength in numbers and pushing for pandemic investment, pushing for special clauses, in agreements during pandemics and so on and so forth. But I want to zero in on the local because that's where we are. And one of the things we have recognized is that for PHC to succeed, people-centeredness must be emphasized because in our budgets, we still find that we are very curative-centric. We talk about prevention, we have made a case for prevention, but we still see that when we go to the table, it's the private sector, the healthcare providers that are jostling for more money, and the prevention is given a very low budget. So one of the things we are doing as a country is to push for the understanding that there must be more investment in prevention. There must be more investment in the first responders. And in our country, the community health promoters are now recognized as a healthcare worker cadre. And so what we are pushing for is that they get paid because, those pronouncements are very good, very progressive, but, you must put your money where your mouth is. And so that's what we are doing as HENET and as CSOs. And so I just want to give you one impact in the GFF-funded RAMCA program. And one of the things that we have done as CSOs is evaluated the first investment case because we were not involved. And we were catching up, we were running to catch up, and we did sensitization because at the community level, the county government knew it as THS, and we were talking GFF. And so we had to bridge that knowledge gap. The second thing we did is evaluate the investment case with a view to looking at whether it was gendered. How gender sensitive was it? And so we realized that there are many things that were missing. And in the next iteration, we have been in there, pushing for, more awareness about the gender responsive policies that need to be put in place.
Beautiful.
And so that is just one of the examples of what we do.
Margaret, I'm sure if I gave you an hour, you would give me all the examples.
It would not be enough.
But timekeeper has just told me we have only 5 more minutes, and I'm just trying to think, how do we make use of this 5 minutes? So, but Honorable Minister, you became minister this year. Congratulations on that. I am sure that it's been a lot of work. And since you became a Minister of Health earlier this year, can you tell us about some of the recent shifts in how Liberia is advancing PHC currently?
So there's so many being done, but I will just highlight a few.
Sure.
Okay. The first is we have established a health task force, and this task force is to assess all the primary health care clinics and facilities, both public and private, and that is currently ongoing to know where the challenges are and what needs to be done for improvement. We also ensuring that there's availability of essential drugs and supply in the health facility around the country, even at the last mile. We are strengthening the supply chain, and that is why it's ongoing currently. And we also looking at, in the western belt of the country, there's the midwifery school that we have just established that started in October, because we noticed during our assessment, the health task force gave a feedback that in that region, there's 3 counties, we have low midwifery per facility. Right. So we are trying to improve that. But this September, we're starting the midwifery school. So there's many things that ongoing. I could stand all day here, I'll sit and just go on. A lot of things ongoing.
And we celebrate you for that. Again, I know the mandate is not easy, but to have a blueprint.
Most importantly, there's this universal health coverage document that is supposed to be legislated. We have, the president is currently on his desk, and because of the political willpower, I'm sure he's going to approve of that.
Don't worry, we have thousands of people watching online. They'll tweet it right now. Mr. President, do the needful. We celebrate you for it. So let's just jump straight to the quick-fire question, Natalia. What gives you hope from where you sit? And I'll ask the same thing to you, Margaret, to round off.
Well, thanks so much. I think primary health care looks at a life cycle analysis in order to take decisions. And what gives me hope for UNFPA, working on reproductive health and fertility, we listen to what young people say and what they want. There's a great deal of hope in understanding that young people are determined to make a difference. They're willing to engage in intergenerational dialogue. Again, with the life cycle, there's a lot of wisdom in the elders, but there is wisdom in the youth. I believe that there is a lot of hope in understanding that innovation is making a difference and that women's needs will be prioritized when, for example, universal health coverage puts sexual and reproductive health prominently in that agenda. Now we know that women are going to prosper, that they're going to thrive.
Okay. Margaret, what gives you hope?
Well, jumping off from what she's just said, the youth, and for Kenya, the recent protest by youth, for me, as much as it was disruptive, it was good disruption. And I think that the youth have the ability to understand, they have the drive, the zeal, and they are willing to take the nation for the sake of their future. Their digital connectedness, everybody knows Kenya's digital prowess is second to none, really. And so using that, and sparring, giving them the right knowledge, the right tools, I think we have an opportunity to use that disruptive process for the sake of PHC in our country.
Thank you so much. Honorable Minister, I give you the last word. What gives you hope?
The collective determination of the Liberian people, the unwavering support of the healthcare workers, also the unwavering support of the international partners, the political will of the president, and his commitment. That's what gives me hope.
Thank you, ladies and gentlemen, our panelists. Thank you so much.
We move right into our next panel, which is a spotlight on alignment for primary health care. Now, in this conversation, the three panelists who will be joining me will discuss how countries and donors are working together for better. Please allow me to bring to the stage my panelists, Honorable Professor Mohammed Ali Pate, Coordinating Minister of Health and Social Welfare, Nigeria, David Winray, who is the Director of Global Health, the Foreign, Commonwealth and Development Office, last but not the least, Honorable Kumbinzi Chiponda, Minister of Health, Malawi. Please welcome them. Honorable Minister, I'm going to start off with you. No jollof wars between Ghana and Nigeria. Let's not do that anymore. This is for primary healthcare, Honorable Minister. Because I saw how you were looking at me and I knew how you wanted to come at me. But Honorable Minister, let's focus on your government, and congratulations, because I know that the government of Nigeria has an ambitious reform agenda with a goal to crash maternal mortality. We heard about it in Liberia and other countries. How is that going?
I think it started very well. And I think we will be able to crash maternal mortality in Nigeria. The way we're going about it is, where are the women dying and why are they dying? They're dying from postpartum hemorrhage, lack of quality antenatal care, lack of skilled birth attendants, access to referral services and emergency obstetric services, cesarean section, and other things. In addition, there are preventative things that we could do in terms of anemia and all of that. So we're expanding primary healthcare services. We are reaching 8,800 primary healthcare centers as a retail outlets where women can get those services, attend antenatal care, get the multiple micronutrient supplements, the care that they need, and when they come to deliver, to have the services that are skilled and of the quality that is necessary, and the commodities that are needed in there. Retraining our frontline health workers. We said we'll retrain 120,000 frontline health workers. A year on, we've retrained 40,000 frontline health workers in those facilities. These are the anchors. These are the, let's say, interlocutors between the physical facility and the equipment that is there with the women who come for services. Expanding direct facility financing so that the facilities have commodities, but also on the affordability side, expanding the Vulnerable Groups Fund, which we've added 2.7 million poor, vulnerable populations to access healthcare, including for cesarean section, so that that's not a barrier for women getting the service that they need. So I think we've started, and I'm very confident that we will build on the momentum together with all the partners that we're working with and our government at the federal level, state civil society organizations, and the private sector to have this push to crash maternal mortality.
Absolutely.
In Nigeria.
We believe it'll happen. And David, I think that's where I bring you to talk about, the UK has been a long-standing proponent of country-led approach to strengthening health systems. What does that mean in practice, David, for a donor government working with all these countries?
Yeah, so it's, well, first of all, it's great to be here, and it's a privilege to be on a panel with the two ministers. And I'd say kind of the first thing I'd say is it's not a one-size-fits-all approach. Kind of what we are doing and supporting in each of your countries and in other countries is kind of different depending on the particular needs of the country. So I think the kind of country-led approach in this is very important. And I would particularly emphasize, as was emphasized by the previous panel, kind of the importance of primary healthcare in all of this as well, the P and the PHC. I think it's also important, the Lusaka agenda, which people will be familiar with in terms of it's not just about what individual countries can do as donors, but also the approach that the GHIs and others are taking in order to evolve in this space is important. But I think, I mean, there's a ideological kind of reason for doing it, and there's a kind of practical reason for doing it. I mean, kind of ideologically, something that our new government talks a lot about, our Foreign Secretary, David Lammy, is the approach kind of with countries more broadly, of approach of kind of partnership in terms of development, rather than a kind of Western paternalistic approach. And within the health space, that partnership is very much working in order to, in partnership with countries, to strengthen their health systems so that they are able to deliver. And then secondly, on the kind of the practical benefits, I just very much agree with what everyone has said. If you look at all of the rising health threats to countries around the world, whether it's AMR, which we're focusing on in UNGA this week, pandemics, climate change, all of those depend on the strength of individual countries' healthcare systems. You know, there's a reason that we don't give health support to other G7 countries, and we do give health support to countries that health systems require that strengthening. It's extremely important to have. And within the UK, we just had a report of looking at our own healthcare system by Lord Darcy, and that found that for every £1 you invest in kind of health system strengthening, it delivers £14 in economic benefit to the country as a whole. And that those systems that have the investment in healthcare strengthening result, I think it was, in a 15% lower non-elective emissions rate. So the kind of the data is there to lean into this approach, but also the ideological basis for doing it and leaning in is there as well.
Yeah, fantastic. Honourable Minister Chiponda, you know what I love about Malawi's health sector plan? It's centered on one plan, one budget, and one report. And just by doing that, you have pushed the boundaries of integrated service deliveries. Now, tell us about that and how it's going, and essentially, what does it look like at this time?
Thank you so much for the invitation. So basically what we're saying, by having one plan, one budget, and one monitoring and evaluation, we looked at the health sector in Malawi. We have had so many successes in terms of maybe managing HIV/AIDS. We have now surpassed the 95 indicators which are there. Maybe we're about 97, 98, doing so well. And then the other indicators also doing very well. But then we looked at other conditions. We're not doing very well. NCDs, we're not doing very well. Issues of mental health, cancer, cervical cancer for the women, our indicators, they're not good, even up to now. So we said, no, now what is the problem? So we found that the vertical programs, they were doing very, very well because they were well supported. HIV, you have got so many partners supporting HIV, but it is the same woman you save from HIV, only to lose that woman to cervical cancer. You get the point. The same with children. Now there's no longer mother-to-child transmission. It's no longer there. It's not even a threat. But you are losing the same child to maybe cholera or dysentery or something else. So we said, no, now we need all the partners to align to our country plan. As a ministry, as a policy holder, we developed a plan, Health Sector Strategic Plan 3, which we're using now. So we have one plan, and then we called all the partners to sit around the table to say, no, this is the plan for this country. If you're going to come to work in Malawi, support us in the health sector, you have to use our plan. We'll do the monitoring and evaluation all of us together. I think the most important thing is that in that way, we have ownership, we will be more accountable. The other thing was that we had so many strategic plans, agreements with so many different partners. So we had so many duplications, wastages as well, and inefficiencies, you know. But now we have improved on that. There are no more duplications because we sit around the table. We have HIV program. Who is going to support this one? Then you have another partner say, okay, me, I'm going to recruit nurses for maybe HIV. You say, no, you recruit a nurse. We look at the woman, patient-centered. We don't look at the disease. We look at the woman, we look at the child. You are going to recruit a nurse. Okay, you bring the nurse, but you tell the nurse what to do. We have integrated services now, so that when there's a nurse, they're going to do the immunization, they'll do all the other things, because they're a health care worker, not attached to a program, but attached to the health sector as such. So we are really doing so much better. Still room for improvement, but we're also learning from our colleagues, because I know Ethiopia, they already are doing that. Rwanda as well, they're also doing that, and we have exchanged visits. So it's looking much, much better. And we're so grateful that even our partners, they have really welcomed it and, you know, jumped on board.
Yeah, well, Minister Chiponda, I did a little research on you, and apparently Malawians think you are one of the best ministers when it comes to listening and collaborating with oh, I did my homework. So, you know, so I'm happy that you are speaking with such passion. It means that as I said before, your blueprint is easily adoptable and adaptable in other countries. Bringing me back to you, Honorable Minister Patti. Now, we've talked about segmented and fragmented, you know, collaborators, but I want to bring you to, you are at the helm of, you know, the sector-wide approach for the health sector in Nigeria. What and how do you rely on the concept of alignment and harmonization, as, you know, Minister Chiponda has alluded to?
I think the key is really to say, for the country, which is ultimately responsible for the health of the population, what are its priorities? Where does it want to go? Once we did that, between the federal government, the 36 state governments, in consultation with private sector and civil society, we engaged with our development partners to look at what are they doing as well, because as Minister Chiponda said, hyperfragmentation leads to inefficiencies, duplications, huge wastage, I would say, in resources on all sides, on the public, on the government side, but also on the development partner side, and say, this is our direction, this is the direction of travel, come along with us. And we signed a compact which for the first time says, here are the expectations, here's the offer, here's the ask of you, here's how we're going to track our performance, here's the accountability mechanism that we'll have on a quarterly basis between governments at different levels, but also with the development partners. And then insisting on shifts in behaviors, because I think the inefficiencies, the hyperfragmentation is very convenient. We are actors who thrive on that actual inefficiency within the overall. They're doing good, but how do we come together, change our behavior to look at the limited resources available and to channel them towards the important priorities? In this instance, population health outcomes, maternal, newborn, child health services, essential care for women all over, focusing on primary health care, focusing on service delivery, not work in Abuja or flying all over the place, but really shift to the front end, because what women, children, what the poor and vulnerable are asking for are very simple things. They want immunization to be delivered. They want quality antenatal care. They want reproductive health services, family planning. They want to be treated with respect when they come to, they don't want big meetings in Abuja. So collectively, that requires changing our own behavior in government, but also it requires the change in behavior of our partners to move from their comfort zone to where the problems are, because the needs are simple. The tools, I think we have tested them for many years, and we know what will save a woman's life. So that's the effort that we have been embarking upon. I think many of our partners, 17 of them, signed that compact, witnessed by the president, and all the 36 state governors in Nigeria signed it, and we're implementing. We've had the quarterly performance dialogue for the first time to say, here is where we are. Imperfect the data may be, at least we have some basis to see where we're going.
Absolutely.
Yeah.
Absolutely. And David, we don't have a lot of time, but care to highlight perhaps maybe one reform across PHC that perhaps FCDO has supported and what you learned from it?
So in terms of, what we've learned, so I'd say you need, I would say first more money for health, but also more health for your money. So it's the value for money outcome in addition to the amount of money that's going in, and that's money domestically, IFI reform. From others. I would underline coordination, not siloed, coordinating, bringing everything together. I would underline third, this is a long-term investment. You can go and do something and deliver an immediate return. Investing in health systems takes a longer-term perspective. And the thing that I would highlight above all is the impact of climate change on health, which of course WHO has highlighted as the biggest threat, in that many countries' health systems are having to run just to stand still because of the increased pressures of climate change on the health adaptation, the health burden.
Okay. Minister Chiponda, I'll give you the last word, if you don't mind. And basically, it's a two-part question. And perhaps I'll come back to you if we have enough time, Minister Patti. But in what ways is perhaps the systems level approach driving better, driving health outcomes better? And also, from where you sit, what's the key point as far as PHC is concerned that perhaps our leaders out there need to pay attention to?
Like the previous speaker, the first panel, I think she was the lady from Kenya, she said, UNFPA, primary health care, that is the backbone of the health sector in each and every country. You get it right at the primary level, you are good to go. Because that is where almost 80% of our people are, in the rural areas. So you better take good care of them. So for us, it has really worked because, like I said, integration of services has been a key. In those days, you would have an HIV clinic on Monday, and then you have NCD clinic on Wednesday, and then you have another clinic on Thursday. In a village setting, time is money. You have to go out to work for you to eat on that day, on a daily basis. So you can't afford the 3 or 4 days of your week going to clinics. You can't. And you expect to have good outcomes. It cannot happen. It cannot happen. I'd rather go and, try to get something for my children than if I have pain, I will, say, no, the pain, I'll see what I can do. So integration, whereby you go for the child is going for the whatever, and the mother is going to get family planning services. They can also do the cervical screening. At the same time, the same clinic. That saves a lot. So really, it has really changed, and it has brought the services closer to the people. So really, it has been a game changer.
Honourable Minister Patti, apparently I have 30 seconds. I mean, speaking to your leaders out there, because we want to move from commitment to action. One key point about PHC that you would share with your fellow leaders?
I think it's the quickest, most efficient, most effective way that you can reach the people with the services that they need. Investing in them gives you health dividend, economic dividend, but also political dividend for politicians out there.
Yeah. Well, thank you very much, honourable ministers. Yeah. Well, I'll give you the honourable minister as well. Esteemed guests, thank you so much for your time. Do please take your seats. David, I've just promoted you, but that's fine. So the last panel essentially is a call to action, mobilizing support and driving change in primary health care. And my panelists for this session are the Honourable Minister of Health, Public Hygiene and Universal Health Coverage from La Côte d'Ivoire, Honourable Pierre Dimba. We're also joined by the youth of tomorrow's voice, Christina Chilimba, founder and executive director, All for Youth. We're also joined by Honorable Budi Sadikin, who is the Minister of Health, Indonesia. Last but not the least, Juan Pablo Uribe, who is the Global Director for Health, Nutrition and Population, World Bank and Director, GFF. So ladies and gentlemen, I need all your energy for this very last one. Because these are calls to action, and we are going to change the world. Leave no mother, leave no child, leave no adolescent behind. And particularly for this session, I'd like to ask that you grab your translation gadgets because we will be speaking in French pardon me, and in English. And for those of you who are with us online, please do tap on the language link at the bottom of your window or your screen. Essentially, lady and gentlemen, let me start off with you. Je voudrais commencer avec vous, Monsieur Dimba. Comment la Côte d'Ivoire mobilise-t-elle les agents de santé communautaire et investit-elle dans les infrastructures pour mieux répondre aux besoins de la population, ministre?
Je voudrais d'abord vous remercier les initiateurs donc, de ce panel qui est sur ce sujet très important. Comme ça a été dit, les soins de santé primaires sont essentiels pour avoir un système de santé qui soit résilient, qui puisse faire face aux enjeux de la santé dans nos pays. Surtout que nous savons tous que nos pays traversent des moments difficiles où les différentes crises ne permettent pas à nos États de doter la santé donc, de budgets conséquents. Donc le défi, ce n'est plus tellement la quantité ou le montant du budget que vous avez, mais c'est la façon d'affecter ces budgets pour qu'ils puissent répondre aux besoins des populations. Et notre pays a travaillé donc à avoir un système de santé qui soit à la fois résilient, robuste, basé sur deux axes essentiels. D'abord, il faut donc travailler à ce qu'il y ait donc l'offre de services. L'offre de services à travers un système de santé, comme ça a été dit, qui soit proche des populations. Parce qu'effectivement, une bonne partie de nos populations ont des ressources limitées et les moyens ne leur permettent pas d'aller très loin pour bénéficier des soins. Les études ont montré que plus de 40% de la population ne pouvaient pas avoir accès à des soins parce qu'ils n'ont pas les moyens de se déplacer pour aller donc, dans des établissements, même quand ça existe. Donc nous avons travaillé à élargir le réseau de soins en construisant des établissements. Cette année, par exemple, nous avons construit plus de 200 établissements de proximité, réhabiliter les établissements qui existent. Il y a plus de 400 qui ont été réhabilités pour qu'ils soient aux normes et étendre, comme ça a été dit, à différents services pour que ce soit des services intégrés. Et nous avons multiplié les ressources humaines en santé pour que les zones éloignées puissent bénéficier du personnel de santé qui soit à la fois qualifié et en nombre suffisant. Et vous savez que la technologie nous aide lorsqu'on ne peut pas avoir des agents de santé partout, à faire intervenir des spécialistes dans des zones reculées. Par la télémédecine, nous avons fait des expériences qui sont vraiment très concluantes. Et je pense que la clé de l'adhésion des populations à des soins de santé primaires, c'est surtout d'impliquer les populations, la communauté, aussi bien dans la gestion, dans les prestations et surtout dans la prévention des maladies. Et à ce niveau-là, donc, je pense que nous avons recruté plus de 12 000 agents de santé communautaire qui travaillent pour délivrer donc ces soins. Mais en même temps, il faut travailler sur l'accessibilité des populations. Une fois que vous mettez le service à la disposition, tout le monde n'a pas les moyens d'avoir accès à ces services. Donc d'abord, nous avons rapproché les services. Donc aujourd'hui, 80% de la population est à moins de 5 km d'un centre de santé, ce qui leur permet justement donc, de se déplacer par leurs propres moyens pour aller à ces établissements. Et nous allons poursuivre. Mais également, nous avons bâti un système de couverture sanitaire universelle qui est obligatoire, où la cotisation est de 1 000 francs. Et les populations vulnérables sont prises en charge à 100% par l'État de Côte d'Ivoire. Aujourd'hui, nous avons sur une population de 30 millions d'habitants, plus de 17 millions qui sont déjà enrôlés dans ce système et qui peuvent bénéficier donc des soins. Et nous avons donc pour cela décentralisé les centres d'enrôlement dans les marchés, dans les écoles, dans les coins ou dans les villages. Et des camions mobiles se déplacent pour enrôler les populations. Parce que même si c'est gratuit pour les personnes vulnérables, ces personnes peuvent ne même pas avoir les moyens de se déplacer pour aller se faire enrôler, quoique l'enrôlement est gratuit. Donc tous ces éléments-là permettent aujourd'hui d'améliorer notre système de santé. Et il faut le dire, comme les uns et les autres l'ont dit, notre système de santé ne sera résilient que si la base, qui est le système des soins de santé primaires, sont renforcés. Et c'est ce que nous sommes en train de faire.
Merci beaucoup, Monsieur le Ministre. Christina, I move it to you. Now, you have talked earnestly and consistently about the devastating consequences of climate change on women and girls. So what works in bringing more attention to this issue, Christina?
Okay. Thank you very much for that very important question. I think first and foremost is for all of us to understand that climate change is not just an environmental issue, it is a human rights crisis, particularly for countries like my own, Malawi, who have experienced its impact. Now, one way to shed more light on this, to give much pressure on it, is by amplifying the voices of those who have really experienced its impact firsthand to policymakers. Allow me to share a story of Mercy, a 15-year-old girl from Chikwawa, Malawi. She's one of the girls that we supported through our organization. Mercy always dreamed about being a nurse, and she was working her way towards that. And then climate change hit. We faced Cyclone Freddy, which washed away all her family crops, a source of their livelihood and survival. Mercy was then married off to an older man, and that was to just, reduce the financial pressure on her family. And guess what? That was the end of Mercy's story, Mercy's dream. Now, Mercy's story is heartbreaking, I agree, but sadly, it's not a unique case. Thousands of girls across the world are experiencing the same fate as climate change pushes families into desperate situations. What more can we do? We have realized that, amplifying the voices of young people and those who have been directly affected is incredibly powerful. Yeah. All for Youth, we have managed to create partnerships with the support from organizations and leaders, but organizations like the GFF. And these partnerships have helped us to develop stories that we have used to present to decision makers and policy makers. One of the other plans that we have is to at least engage women as climate champions in their communities, to advocate for climate resilient policies that will consider gender impact. Now, is it working? Yes, we are seeing encouraging progress. I would like to highlight that, for example, in our country, we have gender considerations that are now being included in climate change management policies. We are seeing health budget allocation shifts. We now have a maternal newborn child health budget of its own. We have a youth-friendly health budget of its own, courtesy to the One Plan. We also have, and this is far and beyond the family planning budget itself, that has seen increase in the fiscal year from 500 million Malawi kwacha to now currently 700 million Malawi kwacha. And I would like to highlight that we are enthusiastically working towards the 1 billion target. Okay. And allow me to take this opportunity to acknowledge my minister, my mother. I like to call her that because she's been very supportive, Honorable Minister Chiponda, for her efforts in what she's championing. Sharing these real stories, collaborating with partners, by working together, it's my belief that we're slowly and surely shifting the needle. Thank you.
And the needle has nowhere to go but forward.
Exactly.
I love that. Minister Sadikin, tell us how you are leading an ambitious transformation agenda in the health sector in Indonesia.
Yes, with 280 million Indonesian people spread over 17,000 islands, it is really a tough job. So what we did is, I'm lucky that I'm inherited with an existing primary care system. So what I did is revitalizing them. Number one means that we revitalize, expand these 10,000 primary care clinics owned by the government at the district level, down to 85,000 at the village level and 300,000 at the hamlet level. That is the first thing that we do. And then we equip them with needed devices like anthropometry. We focusing them to do promotive and preventive, immunization, screening, and health educations. And then on the screening side, we deploy devices with the help of my friends here, Juan Pablo, give me $4 billion. So we deploy 300,000 anthropometric kits to screen the nutrition level of babies. We deploy 10,000 ultrasound, thanks to Juan Pablo, to detect the babies and pregnant mothers. We deploy 10,000 EKG to screen the heart conditions of the adult. And then the second revitalization program is we expand the target group. Before, Indonesia is only focused on pregnant mothers and babies, but our population are aging. So we expand the promotive and preventive not only to pregnant mothers, baby, but also to children, adult, and elderly like me, 60 years and above. You know. And then after that, we do in the revitalizing, in retraining the people. This is the most difficult one. Because we have the doctors only stop at 10,000 puskesmas. Below that, at 85,000 sub-primary healthcare unit, we have midwife and nurses, and we have community workers, 5 for each 300,000 hamlet, which is 1.5 million. So we re-educating them how to take care of the health conditions of the populations. And that is the most difficult one. And then the last thing that we do, we digitalize everything.
Yeah.
And it is needed, creating application easy. There's many smart people in Indonesia. The problem with us is 17,000 island, there is no internet connectivity. So 2,700 puskesmas are very weak. So that's why I persuade a rich guy, American guy called Elon Musk, and invited him to come to Bali. We signed an agreement, get a very deep discount on Starlink, and Elon Musk is happy because then I can get access, close to 300 megabytes per second, if I'm not mistaken, better than my house in Jakarta, at a remote island like 1,000 kilometers away from Bali, which is in the middle of nowhere. So those activities are what we are doing in the puskesmas. And last one, which is very important, as an ex-finance guy, the financing.
The money.
The money. It's not only from him, but also we identify as when we decentralize the government, the source of funding and uses of funding is very, very messy. Very, very messy. With the help of him also, thank you. Juan Pablo helped me a lot. Juan Pablo helped me a lot, not only money, but also with resources and people. Ado also helped me. And then we can identify, now we work with the World Bank to identify the source of funding, whether it's government budget, central government budget, local government budget, which is the profitability of the unit, and also with a national health insurance scheme, how the source of fund is being integrated in each of the 10,000 primary care clinics, and how do they spend.
Right.
So I don't have to pay the electricity, and the regional government also claim that they pay for electricity. And then, the national insurance scheme that claim also they pay for electricity. So these are the things that we get help from the World Bank to analyze and maximize the funding for this.
So Juan Pablo, light at the end of the tunnel. There is hope. You're smiling. So, of course, there definitely is hope. But based on what you've seen, what do you see as the recipe for building this resiliency?
Anita, thanks. Let me start with two quick parentheses, and sorry for that, but I'm going to be very brief in the response to resilience. The first one is a huge thanks to you and to everybody who put this event together. So from my side, everybody around there, thanks so much. The second one, I'm so happy seeing the GFF instrument owned by ministers, leading the way in their countries for improving outcomes for women, adolescents, and children. And that's very important for us. Now, to the resilience question, I want to highlight 4 features that we've seen from the World Bank in the response to COVID. Understanding resilience as the capacity of a system to adapt to a shock, to be flexible, to respond and scale up to that shock without stopping to do what it has to do in essential services. In an example, vaccinating for COVID without stopping vaccinating for everything else, just as an example. The first element, universal health coverage, and summarize as the trust of citizens, and we've heard the examples of being able to access quality, humanitarian, well-oriented services with financial protection, without having to go into their pockets and go into poverty. So this trust in UHC is fundamental, and you can see it across the countries that did best. They had that baseline. For that to happen, you need the primary health care working. And you also saw in COVID, you saw in those systems where the person with fever or with mild respiratory conditions, when this person could access a primary health center in a timely way, the outcome would change. And I'm sorry, that was COVID. That's how it unfolded. When the PHC was not there and the trust of UHC was not there, people were delayed and the outcomes all worsened. The third element, and we've heard it here, and it's so nice to see ministers who are exemplifying this in their work. Minister Budi, for example, here, is partnerships. Because you cannot be resilient by yourself. Again, in those moments, you need to reach out to others. I saw it perfectly, for example, in middle-income countries who were able to bridge the private response and integrate it to the public response as a unique health systems response. And those systems who were able to partner quickly had a better response. And let me conclude, Anita, by something that we should never take for granted, but we're seeing it here present. And it's leadership and institutional capacity. They are not spontaneous. We need to look for leadership and for capacity to implement these incredible reforms.
Thank you so much, Juan Pablo. Monsieur le ministre, la Côte d'Ivoire a réalisé des progrès considérables et félicitations. Quelles sont vos priorités dans un futur proche et quelles stratégies déployez-vous pour les atteindre?
Ben, écoutez, nos priorités sont orientées, comme on a dit, vers les femmes, les enfants, parce que c'est à ce niveau-là que nos indicateurs de santé sont encore mauvais. La mortalité maternelle reste encore élevée. La mortalité infantile, mais également donc, la plupart des maladies que nous avons, comme le paludisme, donc, affectent prioritairement les populations donc, qui vivent dans des quartiers pauvres. Donc c'est un peu sur tout ça que nous travaillons et notre stratégie est basée sur 3 éléments. D'abord, il faut prioriser, on ne peut pas tout faire. Il y a une priorisation donc, que nous faisons et nous faisons en sorte que l'ensemble des partenaires s'alignent sur nos priorités. Et il y a une intégration des services orientés vers les personnes, c'est-à-dire que, comme il a dit, ce n'est pas parce que vous êtes en train de faire la vaccination contre Covid que vous ne pouvez pas faire la vaccination contre le paludisme. Parce que vous n'allez pas demander à quelqu'un de venir se vacciner un jour contre la Covid. Quand sa maman vient, il faut que l'enfant soit là pour que la famille puisse avoir les moyens de mener leurs activités pour avoir donc des ressources pour vivre. Donc il y a une intégration et nos centres de santé au niveau primaire délivrent l'ensemble de ces soins essentiels. Aidés par les agents de santé communautaire qui vont donc dans les communautés délivrer ces soins. Et ça a permis d'accélérer ces choses. Tout à l'heure, j'ai donné quelques résultats, que ce soit pour la construction des établissements de proximité, que ce soit pour la couverture maladie universelle mise en place. Ça n'aurait pas été possible sans le partenariat que nous avons avec le CIFF, la Banque mondiale, l'USAID, qui nous a aidés à recruter des agents de santé communautaire. Mais tout cela est basé sur nos priorités. Et les affectations sont faites sur ce qui permet d'avoir l'impact le plus important au niveau des communautés et des populations.
D'accord, merci. Christina, as an advocate for youth, what are you calling on governments and international community, the international community, to do more of? Not tomorrow, not next year, but right now.
Thank you, my sister, for that opportunity. I think first and foremost is we have to understand that we need to translate the evidence that we have into action and programs. I think that has been a common mantra for this UNGA this year. So for me, I think I will be calling forth governments and international communities to, number one, invest in programs that impact adolescent girls and young women. Not only that, but programs that ensure that primary health care, which has been talked about here, is able to stand the impact of climate change. And the second one would be youth-led organizations need to be in the spaces where policies of climate change and health are being shaped. So young people need to be in those decision-making spaces. The last one is that we need urgent action to climate change. That is one, youth-focused, and number two, gender responsive. This is very, very critical. One thing I'd like to highlight when young people come in this space is always like, oh yeah, they come and ask for things, but like, we are not asking for handouts, or are we asking for just money? We are offering partnerships that will help to tackle the world's most pressing challenges that we're facing together.
Fantastic. I love that. Please, a round of applause for the youth of tomorrow.
Minister Siddiqui, I jump straight to the quick fire question here. From where you sit, what is the number one action that is needed?
Please stay healthy. It is much cheaper and it's way better if you keep healthy. So eat well, exercise well, rest well, and also think well. And if God asks you to see him, you go see him right away without any sickness.
Well, thank you very much. I really wasn't expecting that, but listen, this is probably the highlight of my conversation this morning. Eat well, take care of yourself so you don't have to worry about anything else. So Juan Pablo, we finish off with you. Your final word of the event. What's your take away from the last hour and a half, all these wonderful conversations, all these different factions and communities and societies and ministers, individuals, the youth of the world? What's your final takeaway?
Minister Budi, by the way, is an example of what he just said. I can testify that, and it's such a beautiful recommendation, Minister. We need to keep it. I'm ending this event. I'm extremely happy. Smiling is also part of being healthy, and we need to smile. It's important to smile to each other. I'm very optimistic, Anita. I'm very optimistic. I think there's a combination here of fantastic leadership coming from ministers that I admire, coming from civil society, Christina, which I admire. I wanted to congratulate you and others who have brought down the voice of communities and patients and families. I think that we have the instruments. I think that many times we're asking for more money and looking for more money, but with what we have, with the partnerships we have, with the resources we have, with the ideas and the innovations, Minister Pate, that we have and that we can learn from leaders like you and others, I think we can make incredible progress. I think we don't need to wait for anything else to happen. If I could go back in my life to past responsibilities after learning from you, I would focus a lot, again, in making things happen all the way down to the community. And it only happens when people feel that they are empowered and that they can lead in making those changes in each and every one of those primary health centers without the ministers looking at them. They need to own this agenda. They need to be empowered. They need to be part of the community and know that the community trusts them. And all those things, I think we can do them now. So it's really a call for that, to try to go out of this room, which has been fantastic, optimistic, but feeling the urgency to take action at the national, subnational, and local levels to transform reality. It's the only way in which reality will change. Anita, I was coming in and I was telling Luke and our GFF colleagues that we always know what needs to be done, but we're still waiting for something to happen to do it. We sat here with a great sharing from you, ministers and civil society leaders who are making change happen. So congratulations and thanks so much.
Thank you so much. And for you, those of you here in New York, it's a crazy week. I know you're running off to bilateral meetings and the like. I could see some people just, shaking their legs. They need to leave. But listen, not without saying a big thank you to our partners. USAID, we love you for doing this global financing facility. We've said it so many times. You are the mechanism of the generation, really. The World Bank, thank you. Foreign, Commonwealth and Development Office, thank you so much. And Children's Investment Fund Foundation. And last but not the least, the people you don't see, the technical crew. Thank you so much for making this happen. Brunswick, we love you. So until next time, when we've got to have another conversation, don't let it be about talk. Let it be about moving commitment to action, and do prioritize primary health care wherever you are. My name is Anita Erskine. Have a blessed day.